Okay, welcome back. So now I'm going to present to you our next speaker. Dr. Dentonio Worrell is the current commander of the U.S. Army Dental Health Activity in Hawaii. He was born in Brooklyn, just like me, in New York. He spent his formative years in the island of Barbados with Rihanna and returned to the... Okay, I lied on that one, but yes, from the island of Barbados, and returned to the U.S. where he earned a bachelor's in science in applied mathematics and statistics from the University at Stony Brook. He earned his DDS from the University of Maryland Dental School, and upon graduating, he direct commissioned in the U.S. Army Dental Corps. After practicing for 5 years as a general dentist, he earned his certificate from the Fort Bragg, he wanted to brag about it, endodontic residency in 2011. And became a diplomat of the American Board of Endodontics in 2012. So he got to the root of the problem. He has practiced in the military and private practice in upstate New York. I swear, Layla's not gonna let me do this again. New York, North Carolina, Belgium, Virginia, Washington State, and Hawaii. Recently, he has taught endodontics in the Hawaii AEGD residency. In 2018, he was a member of the American Dental Association Institute for Diversity in Leadership, and 2019, the American Association of Endodontics Leadership Development Program. He's a current member of the AAE's Practice Affairs Committee. Dr. Worrell is married to Dr. Gentle Worrell, DMD. They have 2 children together. They love exploring unique and magical places, and thank you for your service, Dr. Worrell.
I guess I have to hold this? Okay. That might be a little easier, I guess. Sure.
Just say something.
Okay. Well, good morning, everyone. I know that this is not necessarily the most exciting. Yesterday we came in to, do the mentorship summit for the students.
Testing.
And we had some students that just went through their endo rotation, and they told me how horrible it was. So, how do I? Oh, I'm doing it the wrong way.
Okay.
Okay.
Right here.
Okay. Thank you very much.
You're online. Can you do testing?
Okay. Hopefully, y'all can hear me online. All right, so first off, I need to give a huge shout out to Miss Vanessa Emerson. She really came through. I was supposed to be the pinch hitter and go off first, but we had some technical difficulties, and she went home and transferred the files, and now we have the presentation that we'll present to you. So thank you very much. Really appreciate that.
Dental Speaker Institute.
And she's from the Dental Speaker Institute, so thank you very much.
Yes.
So as we say in Oahu, aloha.
Aloha.
Yeah, you guys been there. Okay, all right. So today we'll be speaking about endodontic retreatment or endodontic revision. Okay, and that's essentially what we do when we are managing post-treatment disease. Okay, how do you diagnose and treat those cases where our patient is not responding the way we would like to initial therapy? All right, so as mentioned before by Dr. Glavish, and thank you for that. Where's Miriam? Where'd she go? There you go. Thank you for that phenomenal introduction. She's been rocking all day long, so thanks for that. All right, so next slide. All right, so I have to give a disclosure statement since I'm in the military. I received no financial gain from any companies that I may mention during this presentation, and my opinions do not represent any official opinion of the U.S. Army or Department of Defense. All right. So now that's out of the way. During my bio, I mentioned that my family and I love exploring some magical places. So I hope to share a couple of those with you during my presentation. Since we have students here and they think endo is horrible, hopefully that'll spice it up a little bit. Okay. All right. So magical place number 1. Has anybody ever seen this? Anybody have any idea where this is? Believe it or not, this is on this earth. It's in America. Oh no, not Barbados. So this is in a temperate rainforest. Usually you hear about tropical rainforest. This is a temperate rainforest, but this is in Washington State. So in Washington State, there's a national park called the Olympic National Park. And this particular area is called the Hall of Moss. And way in the background, you can see like my family, my wife and my 2 kids walking down the pathway there. It's Washington State. All right. Today we're going to talk about, this is our outline for today, definition and purpose of retreatment, stages of healing, the causes of post-treatment disease, prognosis, the likelihood of outcomes, and then like some of the armamentarium we use and a retreatment sequence that you can employ your practices. Okay. All right. So what is retreatment or revision? And according to the AAE Glossary of Endodontic Terms, it's a document that's revised every couple of years and it goes over. Believe it or not, we actually have our own Bible in endodontics of definitions and dictionary. But a procedure to remove root canal filling materials from the tooth, followed by cleaning, shaping, and obturating the canals. So if you look at that final line, it's essentially initial treatment. So the real thing about retreatment is just getting access against that apical third of the canal after the root canal was completed. All right. So the AAE, American Association of Endodontists, puts out usually every 2 or 3 months, they'll put out a Colleagues for Excellence, which is an excellent newsletter. Typically, they mail it out to all general dentists, so if you're on their mailing list. But this one's from the spring of 2017, and it was specifically about retreatments and doing clinical decision-making to help general practitioners make decisions on when to refer to an endodontist, when to keep things in-house. So it's an excellent guide. All right, so why do we do retreatment? To alleviate post-treatment disease. Now, a lot of dentistry is marketing. Dr. Golden, he talked a little bit about that. You could tell he's a marketing machine, did the selfie and all that in his practice, And so we use clever terms. So we don't refer to failures in endodontics. We talk about post-treatment disease, unideal outcomes. This language is a lot more positive for our patients. So, all right. So we want to talk about like the success or failure. So what's a patient's definition of success? So we have some practitioners and we have some students. What do patients care about?
No pain.
No pain. Anything else?
They can chew.
Can they chew? This is a great audience. Do I have any pain? Can I eat with this tooth? That's typically all our patients care about, okay? All right, but as practitioners, we need to have a little more stringent criteria when we're referring to these cases. All right, so when it comes to success, much like beauty, I'd say success is in the eye of the beholder, okay? So we refer to success in terms of stages of healing when we're talking about the outcomes. So we usually refer to it as being healed, healing, or non-healing, or in a state of disease. That's usually the criteria that we'll use when we're talking about our outcomes. All right, so let's go over these in brief. So healing, usually is going to be a reduced radiolucency and or clinical normalcy. So when we're talking about that, we're talking about what? Absence of pain, no percussion sensitivity, lack of mobility, just clinical normalcy, okay? So in this case, back in 2009, initially when we first saw the patient, they presented, with that large radiolucency, but then after about a year, you can see that there's been radiographic fill in that in the furcation area. This indicates that the tooth's actually healing. So at that point in time, we decided that we're going to go ahead and put an adequate coronal restoration and then put a crown on this tooth. It's healing. Journal of Endodontics has a whole article on this in the October 2012 volume. All right, so non-healing. So that's when we have a persistent radiolucency or persistent symptoms. Patients continuing to have symptoms long after treatments occurred. In this case, you can see that there's a separated file in that distal root. So that's what we call post-treatment disease. So same here, 2 years later, you can appreciate that the radiolucency is still the same size, And at this point, the patient's actually starting to present with a sinus tract. This is something that we need to address. All right, so what's the cause of post-treatment disease? All right, so you'll have a couple of different causes, and usually it's ultimately because of bacteria. That's the cause of all periodontitis, okay? So what is the goal of endodontists? Does anybody know? To what? To treat the pulp, okay. We are treating the pulp.
To get the patient out of pain?
Get the patient out of pain, yeah. Those are some of our objectives. But we have a formal definition that we would say. So the goal of endodontics is basically the prevention and treatment of apical periodontitis, inflammation around the periodontium, okay? So, and usually it's because of bacteria, and it's either bacteria that's intraradicular, so as demonstrated here, within the root canal system, extraradicular, and usually that was caused by actually us pushing bacteria outside the canal, during the over-instrumentation. It can also be due to foreign body reactions, and a lot of people don't really know about this. Sometimes we tend to use paper points to dry the canals. Well, if you get too much cellulose fibers outside of the canal, it can actually precipitate a foreign body reaction in some individuals. And then true cysts, okay? And true cysts, usually if they're persistent, we can't treat them from root canal therapy. In those cases, we actually have to do surgical enucleation. All right, so cause of post-treatment disease. So some of the contributing factors: untreated canals. Pretty sure, I know we have some students here, the MB2, the elusive MB2. Poorly cleaned canals, poorly obturated canals. You see a lot of poor in this. Overextensions of root filling materials. And then coronal leakage. We'll spend a little bit of time talking about that. And then complications of instrumentation. As endodontists, usually that's a lot of the referrals we get are cases where they've been ledged, or transported, and those are things that we know have to try to bypass. All right, so in this case, we have, so hopefully you can see really well on here. On this screen, I don't know if y'all can see online really well, but I'll try to use a little pointer, laser pointer, right? So typically we're taught to follow the PDL. You'll hear trace the PDL. So if you look at this, you can trace the PDL, and I guess can everybody see the little pointer? Okay, there you go. All right, so the PDL goes right along here. If you can't see it, just trust me, I'm an endodontist. So here's where the other PDL is. So usually everything should be symmetrical in the root. So when we look at this, you can see that everything's all to one side of that root. And that's a good indication that there's probably another root canal in this area that's been missed. And there it is right here. Okay. All right. So that's an example of a missed root canal. This one should be a little more obvious. You can actually see, and I can see it clearly. I don't know if y'all can, maybe you can, because we're used to looking at these all the time. Nowadays, and I'll touch on this briefly at the end, with CBCTs, everything is even more evident. But you can actually appreciate there's a canal right here. Yeah. All right, so missed root canals. So in this one, this is that maxillary first molar that everybody dreads. And in this case, same situation. It was an MB2 that was missed. And it was evident as soon as we opened up the canal. So we were able to obturate that and took this shot so that you could see the path that was missed and able to complete that one. So other reasons are also poor obturation. So in this case, you notice on the radiograph on the left, it's really thin, wispy obturation. You have a post, and then you have that radiolucency associated with the root of the tooth. And then on the right, you can see a more robust, girthy root canal fill, and that should heal pretty nicely. All right, perforation. All right, so we got a couple students here. Who's perforated a tooth? Oh, well, okay. Thank you for your honesty. Yeah, I have too, If you do enough endo, at some point it probably will happen. But the good thing is, well, not the good thing, but once you know to manage them appropriately, you can still actually have a decent outcome depending on a couple of factors. So in this case, and our technology's improved. We have bioceramic sealers now that are biocompatible and actually can, in some cases, osteogenic, and we can actually still get pretty good results depending on a couple things, okay? All right, so I'll continue on. All right, so coronal leakage, we talked a little bit about that. So the root canal is super important. We're sealing off the canals, we're preventing bacteria from being in there. But the apical, so that's the apical seal, but the coronal seal is super important as well. And they've done some studies where they found that bacteria can penetrate in as little as 7 days the root canal system, afterwards. So what we try to do is, before we refer back to general dentists, we always try to put a coronal seal on there. We call it an orifice seal. Usually the glass ionomer will flow that over the orifices. If we're really prudent, we'll try to actually make sure that it's something that you can see. Some dentists will use something called permaflow purple, which is really purple. I personally don't like how it shows on a radiograph, so I use some other liners that are see-through so that y'all can see everything clearly once you go through. But that's just so in case, say, the patient, they go and chew, we always tell them, chew on the other side or, hold off a little bit, chewing on that side until they can get the permanent restoration. But in case they go chew some nuts or something like that and break their temporary. So here we have an example. This patient came in and, what was surprising about this patient is that they actually didn't even know why they were there. They told me that, the general dentist just sent me, told me to come to you. Yeah, they had no clue that they were missing fillings in their back of their mouth. But, so we went ahead and removed all of the gutta percha, because they'd been exposed for over a month. We placed a new resin restoration initially just so that we can have a good seal while performing the root canal therapy. Completed root canal. And then make sure that they were healing. Give them another month to make sure they're asymptomatic before proceeding with going forward with coronal restoration in the crown. All right, so in JADA, and this is a little blocked out, but in this article in JADA, you can, is it blocking the whole top? I don't even know how to stop that. But anyway, in this article in JADA, it provided a really nice flow chart as to when to proceed with root canal therapy or when to retreat the root canal. And if anybody wants access to the actual article, just email me or reach out to me and I can get this to you. All right, so this magical place number 2. Does anybody know where this is? Oregon? Ding, 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 ding. Yes, Yellowstone National Park. And if nobody's ever been there, I highly recommend it. I feel like they should be advertising, they need to hire Dr. Golden to go there and just advertise for Yellowstone. It's truly a magical place. I mean, there's hot springs, there's sulfur springs, there's all this wildlife. I think there's only 2 places in the entire world like it where they have that collection of wildlife and geothermic activity is phenomenal. The top picture is the Grand Prismatic Lake, and it's just insanely beautiful. And what you don't get from this picture, well, you can see the steam rising up. What you can't get from this picture is feeling the warmth coming off of that lake, and just the number of different colors. And same thing from the bottom one is the Abyss Lake at Yellowstone. All right, so considerations for retreatment. So now we got to talk about our treatment plan and options. So treatment plan and options when it comes to endodontics are typically the same 4 things over and over again. Do nothing. Always have to, patient autonomy, right? You always have to tell the patient, it's their body, they get to make the choice. That's always an option. It may not be a likely option, but it's always an option that you should present to your patients. You have the option to do nothing. 2, extract the tooth. 3, non-surgical root canal therapy. 4, surgical options, okay? So typically, usually we'll get the best outcome, and I think I go into this a little bit, combining number 3 and number 4, doing the retreatment and combining it with a surgical option when appropriate. All right. So Gorni and Gagliani, they did a study, a prospective study, where they did looked at 452 root canal treated teeth, and then they followed them 2 years out, and then they looked at the likelihood of success following retreatment, and they found that the overall success rate was 69%. But the big bottom line from what they found is that the rate of success changed dramatically when the initial root canal therapy, whether the canal morphology was respected or disrespected. Basically, if you ledge, transported, or destroy that natural path of the root canal system. So they found success in root canal morphology group was 47%. That's basically when it was altered. That natural shape of the canal was altered. But they did find that in cases, so this is an example of root canal morphology altered. Or in this case, where you have some ledges, and obviously they weren't able to get to the apex of the tooth. But they found that in success in cases where the morphology was respected, it was 87%, almost 90%. So when you're analyzing your radiographs or your CBCT initially, that's one of the big things that you want to look for. Okay, is it still following the natural path of the tooth, or has it been transported, ledge, short? All those, excuse me, all those will affect the rate of success. All right, so here we have another example of root canal. So this one, root canal morphology respected. So you see it's still following the natural path of the tooth. That's kind of cool. Natural path of the tooth. There's no alteration in following that path. So there should be a good chance of success with this. And then as long as we follow the natural path. All right, so some other outcomes, outcome studies that were done, and this is how you can relate this to your patients. So Salarabi and Rothstein, they found at 5 years, about 90%, 89% of teeth retaining the oral cavity. Fristad, they found 10 to 17 years, 85.7% of cases were successful. Then De Chavigny, after 5 to 10 years, radiographic success was 83%, and 94% was functional success. So what does that mean? 83% of the time, it was still there. It still looked good. There's no radiolucency developing, or it was healing. But 94% of the time, functional success. Remember what we talked about when functional success is basically from the perspective of the patient. No pain. I can chew on the tooth. I'm good to go. And for some of our patients, you talked to Dr. House during the ethics lecture about, what if it's an 80 or 90-year-old patient? Okay, are you going to go put them through all of the, like a retreatment and then maybe even apical surgery? No. In some cases, if they decide that they want to just keep that tooth, then that may be the right therapy for them. All right, so after we've done everything, the big challenge is to regain access to that apical third of the root canal space. After we've accessed through coronal restoration, then we have to access through core material, we have to remove post, and we have to remove root canal filling material, and then at that point, the rest is pretty easy. Cleaning, shaping, and obturating, okay? So that's what makes retreatment challenging and fun at the same time for endodontists, all right? All right, so but first you have to make a big decision. So who can tell me what the big decision that we have to make first when we're about to treat or not to treat? So we've already covered that. We're treating. What's the big decision we have to make as an endodontist first? In a lot of cases, the big decision we have to make is, do we keep the crown or not? All right, so we're gonna access through the crown and keep it, or to remove it and disassemble the coronal restoration. And there's pros and cons to each approach. But typically, if the crown has intact margins, there's no sign of bacteria, we'll try to keep the crown intact, All right. It's also, cost savings for the patient, if we can do that. All right. So accessing, what kind of crowns do we have to go through? And we have a prosthodontist in the back, so I want to defer to her if, I say anything wrong. But, if you have full gold, PFMs, amalgam crowns, porcelain jackets, Empress, IPS, EMAX, Bruxer. But, more and more we're moving away from, the traditional types of crowns and moving more to, the disilicates? Did I say it correctly? Yeah? Okay, cool. I'm getting eyes up. Okay. All right. All right, so this is some of the tools that we use when we're accessing through crowns, okay? We got transmetal burrs up on the left. We have some fine diamond burrs. That's usually what we're using to go through porcelain. And I don't know, students, are y'all still seeing porcelain fused to metal crowns? Yeah, okay, they're still around, okay. They're probably gonna go out probably within the next decade or so. Then we use a lot of surgical length burrs because, we're under a microscope. We need to see deep into the canal system. And then on the lower left, we have these are called Muntz Discovery burrs, and they're super long, 31 millimeters in length. You can use them in a slow speed, and we use these as well. So these are what they look like. All right. So access, the crown, you always have to remember the crown may be deceptive of the true pulp chamber anatomy. You don't know how much or how little tooth that person left before they put that crown on that tooth. So always bear that in mind. You want to use a diamond round burr to remove porcelain and to prevent fracture. And then switch to your carbide round burr once you've gone through the porcelain if you're doing a porcelain fused to metal crown. You want to locate the tooth structure and then remove the filling material, but being really careful to conserve as much tooth structure as possible. And always use adequate irrigation. All right. If you're removing the crown, these are some of the tools that we use. So on the bottom is a KY pliers, and at the top is a Worrell crown remover. Who's seen one of these before? Okay, the prosthodontists raise both hands. Yeah, I'd love to use those. So it seems archaic, but it actually works incredibly well. So this one's called a MetaLift. Okay, okay, Dr. Boland's seen them. Okay, all right, cool. Yeah, so MetaLift is a pretty cool system, and what this does, it allows you to just create a small pinhole into the tooth, get into the resin material or the core material, and then once you twist it, the crown will just pop straight up. And have a little example of that. You create a little pinhole, gain access to that area, and then you can screw it in, and the crown will just pop right off. All right. So then we have, what kind of core materials do we usually have? We have resin and usually composite. Or some kind of core buildup material. So deep core removal, these are the instruments we're going to use. And when we're getting really deep in there, we're going to primarily use our ultrasonics, which is represented on the left. So you want to move to a slow speed handpiece once in the canal chamber. A lot of us will still use high speed, but when you're getting really deep in there and then visibility is getting challenging, and then also depending on if the person's used dentin colored core material, sometimes it may be really prudent to switch to a slower speed handpiece, okay? You want to remove, or just using your ultrasonics. You want to remove the remaining core material or the orifice, and then take your time. Can't emphasize over and over again. Take your time, okay? Do not create more problems, all right, by perforating. Yeah. Yes, we can address perforations, but the best seal is the tooth structure itself, okay? All right, so there's some examples. So post removal, first step you want to do is expose the post, and you might be able to appreciate here that there's a little bit of gold sticking through right here in the midst of all this amalgam. And then over here, we've removed all of the amalgam around that post, exposing it. So, all right, second step, then you want to remove the cement, because usually that post is cemented in some way or is screwed in, So then we're going to switch to our ultrasonics. These are ones that have diamond-coated tips, and they become progressively small. And then these ones down here, they're pretty, you usually have to turn your power way down, but these are excellent for removing the cement around the post. So we'll use that in that interface. Another tool or instrument we have are these. Okay, so, yeah, and I go more in detail. So on the upper left, we have a Pro Roto burr. And a lot of people don't know, even some endodontists don't know about this. I was fortunate to have an old school endodontist teacher. So he had done like 10 years as a general dentist, hundreds of teeth, just doing endo as a general dentist before he went to endodontic residency. And so he's a wealth of information. He could hand file things in like an hour that the rest of us, even with rotary, might take, longer than that. Amazing. But he introduced us to this, so I'll talk about that in a second. On the right is the Ruddle post removal system, which works really excellent. And it was created by an endodontist, a pretty famous one, Dr. Clifford Ruddle. And then on the lower left is a VTS vibrator tip that we utilize a lot. So yeah, so the VTS tip, see is extra thick. It's got this nice rounded edge, and you can use that to apply a lot of vibrational forces to posts. Just always remember to use water spray constantly when you're really applying, using vibrational energy on posts. So Schwartz and Robbins, they did a study, and they found that in 2004 that usually once you go past like 200 degrees in the PDL, this is what can occur. Necrosis and sloughing away, and that also represents a loss of bone around that tooth. All right, so that Pro Roto burr. So what it is, it has like 6 sides. So usually they talk, my professor, Dr. Mines would call it poor man's ultrasonic. So this is like the ultrasonic before well, it's not actually ultrasonic, but this is like maybe a precursor to ultrasonic. But you use this in a high speed, and it has 6 sides. And once you rotating your high speed on full blast, you usually get about 120 vibrations per minute because it's just knocking the post. So you use your high speed on full blast, and what you want to do is rotate in an anti-clockwise direction, counterclockwise direction around the post. And these work like a charm. Usually if we use some of the other modalities and it's not really budging, I get in there with this bad boy and just spin around a couple times, and you just watch it just spin right out if it's like a screw post. And they're pretty cheap as well. These were actually originally used as scalers like way back in the day, but some endodontists found another use for it. So, all right. So the Ruddle post removal kit works really great as well. What it is it has these trephines up here, and you're going to use those to create. Basically, you're going to machine away the top 3 millimeters of a post, and then what you use is these mandrels up here. And you can see that there's an arrow on them showing you the direction. You screw those onto the post, and then usually you can either unscrew the post using these, or you can actually, if it's a passive post, you can actually use this vise down here to pull it straight out of the tooth. And I have an example of that here. Sorry, we have tooth number 9 here. You have that PFM crown on there. And this is how it looks radiographically as a screw post. And you can see that obviously the margins of that crown are shoddy, as my friend would say, some people would say. So here's how it looks clinically. So this is using that trephine over the post to machine away that top 3 millimeters, basically to have a bite so that mandrel can engage. So this is after you've machined away that. And this is the mandrel in place. And so, as a screw post, you can literally screw this out. Another way, if it's a really, really aggressive post, say if it was passive post, you don't want to do this technique if it's a screw post, but if it's a passive post, you apply that vise that we're showing and realize there's like a little rubber, stopper over the tooth. And then if you want to like apply a little extra oomph, you can actually apply your ultrasonics indirectly to there. Because remember, all these posts usually have some cement around them as well, and that'll help to break it up, the vibrational energy. And that's the post up. That's usually how it comes out. The thing about this, manufacturers, it's all about making money. Usually these are locked into place, so then you have to buy another material. So, yeah. All right, so Dr. House talked about it, and I was like, I hope that I can do my lecture. So who knows what this is? Silver points. So I'm sure the students have never seen any of these. Yeah. There's probably still some of them out there, but they're probably going to be people maybe like in their 70s or 80s, because I think they stopped using these in the 1970s, like maybe early 80s. There's probably still a couple of eccentric dentists out there still using these, because the manufacturers still make them. But the AAE put out a position paper on these years ago, and they stopped using these because it used to be a form of obturation. Remember, dentistry is just evolved over time. Technology evolves, everything about our profession evolves. But these were made of elemental silver, but at the time, and they used to use them to fill canals. I don't know who came up with that idea, but they would corrode and then start to rust, and those byproducts would come out and then cause lesions in the tooth, lesions in the bone. So these are banned from use in America, but, the AAE strongly discourages using these, okay? Land of the free, right? All right, so silver point removal. These are really actually very simple to remove, though. What you want to use is Stieglitz's forceps. And it's funny, because I thought yesterday about taking all this out, because nobody's going to care about silver points, but you mentioned it, Dr. House, so we were meant to do this. So Stieglitz's forceps, they're real easy. They're either offset at 90 degrees or 40 degrees, but they're just like hemostats with a very, very fine point that you can use to engage these silver points. So the key to silver point removal is basically just remove all the gutta percha. Try not to use your burr. You have to be very careful, because if you use your burr, you can snip them off too far down, and then you can't grab them. But usually they'll always be sticking out in the canal just like this. So just carefully remove the gutta percha around them if you see them, and then you just take those Stieglitz and just pull them right out. There they are. That's what they look like. Yeah. All right, so other things that you may see in canals, and depending on where patients grew up or were born, you may see some crazy stuff. I've seen some crazy stuff in canals in my day. But resorcinol, the nickname for this is Russian red. It's a really hard red paste filling. And usually you see this from people that have been, they call it Russian red for a reason, from Russia, Ukraine, that side of the world. Another one is Sargenti paste, which is another one that's been banned because it contains formaldehyde. And then there's another one called N2 paste. And N2, I've seen that one as well in residency. It usually is like a yellow paste. It just looks really weird. But we do have solvents that have been created to remove some of these paste fillers. Endosolve R is usually for resin-based paste fillers, and Endosolve E is for eugenol-based fillers. Those are made by Septodont. All right, so who knows what's going on here? Cotton ball? No. No. Okay. Short, yep. Missed canal, yes. So, I'm going to tell you, there's a characteristic look to this that usually, we call it like a chicken leg, right? Yeah? Or a drumstick, and it starts really thick up there and it gets really thin down here. See, thin down here, thick down here. And usually that's characteristic of what we call a solid core obturator, and the most popular of which is called thermophils. So you will hear a solid core obturator removal. And what that is it's a form of gutta percha where they actually used to use it's literally a solid core surrounded by gutta percha. They used to make them with metal and then also plastic. Now they actually make them with a core of gutta percha surrounded by, alpha phase gutta percha surrounded by another beta phase gutta percha. But the more traditional ones, the thermophils, usually have plastic or metal carriers. And this is just a schematic about how to remove it using one technique called the braiding technique, where you can actually, once you create a little channel around them, you can use some smaller headstrom files, and then you literally braid them around and then pull them right out. Sure.
What are your thoughts on thermofill, like as far as a primary endodontic material fill?
I think we're all different, and I think there's nothing wrong with us using whatever works best in our hands. You know, you'll hear a lot of endodontists say, "Oh, maybe I shouldn't be saying this live." Maybe I'm anti-establishment, but you know, you hear a lot of us saying that, "Hey, you know, we hate them," is because they'll come to us to retreat, but I think, what we should do is actually just educate our general dentists, that are referring to us, because I think it's a great system if done properly. The problem is that a lot of folks don't, follow the guidelines and know how to do it properly. So then you end up with the chicken wing, where and what that represents is all the gutta percha being stripped off that, up in the top of the tooth, in that coronal aspect of the tooth, and the solid core obturator is the only thing that makes it down, So usually that happens if it hasn't been cleaned and shaped well. And that's where we can come in during CE or just come into offices and helping our general dentist referrals, So yeah, keep using it if it works for you. All right, so this is how they look when they come out. You see there's gutta percha out there, but then usually in the bottom portion, that's where, I keep forgetting I have this thing. Bottom portion, that's where all the plastic lies. All right, so thermofill removal, you can use those techniques, and sometimes you can just use a single headstrom, get down there, wind it down into the apical third, and then pull it straight out. But sometimes you can use heat, and I'll talk about that in a second, and push down into there, let it cool, and if you're lucky and you pull out, it'll come straight out. But usually we have like a basket of tools that we use and techniques that we'll use to try to get these things out. All right, magical place number 3. The Black Sand Beach, yes, in Hawaii. That's my son there running across it. And who's ever been on a black sand beach? So this is literally from like 3 weeks ago. It's phenomenal. It feels completely different to the regular sand. It doesn't like stick as much to your regular sand. It feels like velvet. It's awesome. I'll be honest, so I grew up in Barbados, and I thought, beach, black beach, whatever. Oh, it was awesome. Yeah, and then so on the right, and maybe you can't see it so much so that's a green sand beach. And it's green because of this. I forgot what's the name of the stone that's produced. But there's only 4 places in the world that have these green sand beaches, and I believe it's the Big Island of Hawaii, somewhere in Norway, New Zealand, and then I think Galapagos Islands. So this one though, you got to earn this green sand beach because it involves like a 2.6 mile hike just to get there. And then if you look way up here, you might see you might not be able to see it on there, but it's some ladders. It's a little bit of treacherous coming down there, but totally worth it. Well, my wife she's watching. She didn't think it was totally worth it, but she did it for the kids. She did it for me. That's the kind of stuff I like to push the kids. But it was fun. We had some good memories. So yeah, Hawaiian Islands. All right, so last part, so wrapping this up. Gutta percha removal. So we got 3 different methods we can use: mechanical, chemical, or thermal. All right, so these are some of the tools we use: Gates Gliddens, headstroms, GPX, and then Pro Taper retreatment burrs our files were actually created. You can use chemical, so I'll go into that in a second, and then thermal. So as the example on the left, you have the Pro Taper retreatment files that they actually specifically designed to try to pull gutta percha out as rapidly as possible. In the middle here is a GPX. These 2 are GPX files, which are also designed for that, but I think the retreatment files work a little bit better than those, but they're a little more technique sensitive because you can perforate using these. And then Gates Glidden, which I wouldn't use, but some endodontists do use to remove gutta percha. Thermal, so this is an older system, System B, but it still works. It's one of those if it ain't broke, don't fix it things, and they still continue to make it. But it's essentially a heating source or a heating element. Chemically, you can use chloroform. Have y'all used that in school? Have y'all used any? Yeah. Okay, you will at some point. Be very careful with it. But they're all, so it's a solvent. It dissolves, got to perch it very rapidly. It also dissolves your gloves pretty rapidly. Plastic cups, pretty much whatever you get on. It'll destroy your scrubs, so be very careful using it. So nowadays, this is the internet age. Patients come in, they watch stuff on the internet, they have a whole variety of ideas. If they're more holistic, there are holistic options you can use. And one of those is orange oil, and there's been studies done on that. So if you ever get a patient that actually comes in saying, hey, I don't want to use that stuff, usually we just use the term solvent, because if you say chloroform, they get freaked out. They think about movies where people getting drugged and stuff like that. But if they're asking about it, orange oil is something, and I have had patients come in and I'll switch to orange oil, which is more acceptable. The con for this is if you don't like the smell of oranges, the whole office is going to just smell like oranges for probably like a good week. So there's some other ones, citral as well is made in Europe, and then eucalyptol. There's other alternatives to chloroform. And this was a study done comparing all of them and comparing the retreatment file systems. And essentially what they found is that orange solvent was as effective as chloroform in removing obstruction materials. All right, so treatment sequence, access, post and core removal, remove the canal filling material, clean and shape, intracanal. So I like to place an intracanal medicament. This is usually a big thing in endodontics, talking about 1 versus 2 appointments. There have been plenty of studies done, and there is no statistically significant difference between 1 versus 2 appointments. But there is a difference, okay? It's not statistically significant, but there is a difference. And I know too, just personally, and I realize too, I practice in the military, so I have, I guess, time and money on my side versus private practice, where time and money may be a little more of an urgent criteria. However, I choose wherever possible, especially if it's been a long-standing lesion, to do it in 2 appointments when it's feasible. And I base this, for me personally, when the patient has a sinus tract and I place that intracanal medicament, I like to see that it's healed completely before I go and close up everything. And in some cases, some of these cases that are really persistent, they require multiple treatments of calcium hydroxide. Some people will give up after 1 treatment and say that it's a case that's just non-healing, but that's not necessarily the case. Sometimes they just need 3 or 4 applications. And that sounds crazy, but there's a pretty famous endodontist. His name is Dr. Schwartz out of Texas. And he's shown cases of where they've been persistent, and he's done 2, 3 applications, maybe months apart, of calcium hydroxide, and then it'll just heal dramatically, But the problem in private practice is, do you have the time? Will you have the confidence of your patient to go through that extended period of time? How motivated are they to keep their tooth? Just realize that's always an option. And a lot of it's about educating the patient and maintaining their trust. All right, placement of acceptable coronal suture. So all right, let's go through one case here. So upper maxillary, first molar, number 3. What do you see? You see that there's a radiolucency associated with that mesiobuccal root, kind of thin, wispy obturation. It's got a post in there. Distal canal's got a little lesion on it as well. Got a nice little curve. So this one's non-healing. So I'm going to access and post removal. So remove that post that was in there. Gain access to the apical third. And then you want to make sure that, so for me again, place that intracanal medicament. And I usually like to leave it in there minimum a week to 2 weeks before bringing them back in to obturate it. As the obturation, at this point when we took the check film, saw that it was actually a little bit overextended, so we needed to create a new apical stop for that. And that was the pre-op and the post-op. Got a good result. Okay. All right. So just a little bit. So I've been using images of radiographs, a lot of PAs in this, but CBCTs. So it's coming to the point now where the CBCT is pretty much almost mandated, I would argue, for retreatment in particular. So the AAE and the AAOMR put out a joint position statement stating that limited field of view CBCT should be the imaging modality of choice when evaluating non-healing of previous endodontic treatment. So more and more is becoming mainstream and can be almost considered standard of care now to use CBCT if you have it when evaluating, because you're just going to see so much more. It's useful, identify the untreated canals, root perforation. Who's used CBCT and have access? Beautiful. It should become more mainstream. Root fractures you can identify. And there was a study by Mathern where he found that 4 out of 10 teeth that had missed canals using periapical preoperative radiographs versus CBCT. So meaning you couldn't see it on the PA, but CBCT, it was like evident. So consider that. And this is just an example of like what can occur. So here, these two PAs, you can't really appreciate that anything's going on. But on the CBCT, it's evident that there's a lesion, and there's a loss of cortical bone, and in this case, it was a vertical root fracture. Just other images here, just showing like how you can see, and from all angles, what's going on with the CBCT as opposed to PA radiographs. So I would encourage you, if you don't have it in your offices, refer to someone that has it, because you can just get so much more information from CBCT. All right. All right. Summary. So we went over diagnosis, how to ensure proper etiology post-treatment disease, how to access and core removal, remove obturation materials. But the bottom line, though, of the lecture is like know your own comfort level and when to refer to an endodontist. But some of these cases you probably can treat on your own, so be bold. Okay. You have a question?
So we were talking about this earlier. Are your CBCTs a little different than what we use for doing implant planning? So do you guys have thinner slices when you guys are you guys using different, like you guys aren't using iCads, right?
iCads?
iCads, like CBCT machines, are you guys using different ones?
So usually one for a choice for us is like the J. Morita. But yeah, we use thinner slices just to get, a little higher resolution than I assume prosthodontists or for implant placement, because you guys just need like the entire arch. We'll narrow it down to just that tooth. We also want to kind of narrow it down just to that tooth too, because we're not radiologists and we don't want to be legally responsible, because you're technically legally responsible for everything that's on that CBCT. So we try to keep it to the tooth wherever possible. Sure.
I might be dating myself, but are apicoectomies still a thing, or do you guys just
So yeah,
I haven't seen them anymore? But
so believe it or not, I have a friend that's an oral surgeon that called me about a year ago. She was doing an apical. So there's still people doing, but I screamed because she said she used IRM tooth removal, so I was like, oh no. But yeah, so yeah, apicals are still a thing. And actually I would argue that we have even better success rates today with apicals because of microscopes, ultrasonics, because now we have specially designed ultrasonic tips with 90-degree angles to actually get us in there. We have micro mirrors. They're really, really tiny mirrors, so we can keep the bony crypt really, really small. So we have a lot more tools than we had in the past. So the success rates and outcomes for apical surgery is actually a lot higher. And then also our root end filling materials. We have all these bioceramic materials that are a lot easier to use. For a while we were using MTA, and we got good results with that. But now a lot of us are moving to BC putty. And BC root end material, and then also biodentin. they give really good results and they're a lot easier to handle. So, yeah. What? BC putty is a little harder, although so I actually looked this up last night. There's actually a study out of India, but they compared the two and they actually found it was easier to remove some of the remnants of BC sealer, not the putty, but yeah. Okay. Okay, sure.
On that as well, what about for vertical fractures? Are there any advancements endo-wise to safety?
Vertical root fractures? No.
Okay.
Yeah. So if you think about a vertical root fracture, that's like a highway for bacteria. Remember, it's all about bacteria. We can't get around that, not at this stage, but who knows? We're constantly evolving. But I think there'll probably be growing teeth before we can fix vertical root fractures, I think. So, all right. And yet,
Wait, two questions.
Sure.
Being in the military, I know you can't tell me what's in Area 51, but can you tell me who's the bigger baby? Civilians doing endo, like working on them, or a soldier? Who cries more? You gotta repeat that.
Okay, sorry. So Dr. Glowash asks, who cries more? Who's the bigger baby, civilian or military personnel? So I'm biased, but I think our servicemen and women are the greatest patients in the world. They rarely ever complain. They rarely ever fuss. They're usually grateful, especially if it's like so in Hawaii, we operate on the infantry division over there. So they're the guys that if anything pops off in the Pacific, sometimes even in Europe, they're always traveling to Australia, all these, maybe I'm saying too much. Usually they're just grateful. Service members are just, they're the best patients. Anytime, I would encourage any dentist, if you have an opportunity to do like a volunteer event or something like that for veterans, do it. You'll see. They're going to be grateful. They're just always grateful. So,
I worked with the Coast Guard. Oh my God, best patients ever. Just
yeah.
So nice. Thank you for everything. Just love it.
Yeah, they're going to be respectful and yes, ma'am. Yes, sir. Open way. They're going to do it and they'll stay open.
They actually floss.
Yeah. So, yeah. Any other questions, anyone? Sure.
Any big obvious difference when you see a cyst versus an infection? I know there's kind of obvious difference, but for the ones that are really hard to tell, any cheat sheet to that?
So technically, you can only really differentiate between a cyst, abscess, or granuloma by what? Biopsy. Yeah. So it goes back to apical surgery. When we're doing that, anytime we remove any tissue from that, we're going to send it off for a biopsy. And then when that comes back, then we'll know if it's cyst, abscess, granuloma. Yeah. Well, okay, I'll go deep in the weeds. There was a device developed, I think like 20 years ago, called an apexum. And it looked, basically you'd go through the tooth and it had this little spiral edge, and his thought process, you can stick it out the apex of the tooth and it'll whip everything out and then you suck everything up. You can actually probably look it up, Google it. But I thought I'd just add that in because you just made me think about that. Yeah, apexum. Yeah. All right. Any other questions? All right, so thank you for your attention. This is last magical slide. I don't know if you can see it, but there's actually a double rainbow, full double rainbow. Every Saturday morning, for whatever reason, so that's my wife on the lower left. We go for a morning walk most Saturdays, and it always rains without fail. First, she hated it. I love it, but now she just embraces it all. But we get great rainbow views like this almost every week. So, all right. Thank you for your attention.